Okay, so my name is Andrew Packham. I'm one of the consultant anaesthetists at the Leicester hospitals, and I'm the medical lead for our Prehabilitation Services. And we've got Dr. Heather MacKinnon with us, who's our senior physiotherapist in the Prehabilitation team and has done a lot of work setting up the services that we're going to talk about this evening. So what we're going to talk about this evening is prehabilitation and why do we need it? Why do we need to be doing this with patients before surgery? Just about what prehabilitation is. Talk about not just our own work, but who's doing what around the country and different ways that prehabilitation is being delivered. And then we'll talk about our own services in Leicester and where we see prehabilitation going in the next few years. So why? What is fitness? How do you decide if you're fit or not? The US government defines fitness as the ability to carry out daily tasks with vigour and alertness without undue fatigue and with ample energy left over to enjoy your leisure time pursuits and to meet unforeseen emergencies. And for a lot of my patients, the unforeseen emergency is that they've been diagnosed with cancer and that they find themselves needing major surgery or other major cancer treatments. When you have a big operation, tissue damage from the surgery itself generates pain signals and inflammatory mediators that result in you mounting a stress response and your brain setting your body on a different path to deal with the damage that's been done and recover it. So you have sympathetic system activation, releasing adrenaline and similar chemicals. You release more steroid than normal, cortisol, growth hormone, vasopressin, and you get quite a complex system of changes in the immune system. So you retain salt and water in your kidneys so that in case you need it. Your overall metabolic rate increases the days after surgery. So after a big operation, all of your tissues are demanding more oxygen. So you have to breathe more, your heart has to pump harder. It's like you're going for a steady walk, but you're keeping it up for 3, 4, 5 days without a rest. And if you have complications, that metabolic rate may be increased further and sustained for much longer. Your body also changes its balance of energy metabolism. You start to break down protein and muscle to provide the building blocks for new acute phase proteins and also as an energy source. So you do start to chew through your muscle mass in the days after a major operation. So how do we decide whether someone's fit enough to go through all of this? Traditionally, very simplistically, you might have looked at whether someone's healthy or not. Do they have respiratory disease? Do they have cardiac disease? If they've got a long list of medical problems, you might decide that they're not terribly fit for surgery. If they don't have a long list of medical problems, you might say they'll probably be all right then. But it's become increasingly aware that general fitness matters too, and start to ask questions about people's lifestyles and their physical activity to get an idea of how fit they might be. And it's worth noting as well that people who are inactive and unfit do have a higher risk of quite a few medical conditions. So your rates of heart disease go up, hypertension, kidney disease, diabetes, and so on. So an inactive lifestyle leaves you less fit, but also makes you more likely to have comorbidities. When you do have significant lung or heart disease, that can end up directly limiting the amount of physical exertion you can do, but also it makes it less comfortable. If you get short of breath when you walk fast, some people will walk slower. And then when they walk slower, they are then not exercising at such a high intensity and they start to decondition. As they decondition, they find they get short of breath at a lower work rate so they walk a bit slower and they decondition even more. Unpicking all of this and then making a real decision of how fit someone is can be quite difficult, and patients themselves have quite different perceptions of how fit they are and what's normal for their age and their size. So for major surgery, we've moved more and more to objectively testing patients. And this is a patient doing a cardiopulmonary exercise test. We do about 500 of these tests in Leicester a year for patients having the biggest operations that we do. So this gentleman is pedaling on an exercise bike. He's got ECG leads on his chest, blood pressure cuff on his arm, and he's wearing a mask that we can measure how much oxygen he's consuming to do the pedaling work and how much carbon dioxide he's producing. So if you look at the graph on the left, the test itself takes 10 or 12 minutes. He does unloaded pedaling for the first 3 minutes, and then the computer puts the work rate up at a steady rate, and it's just going to get gradually harder and harder and harder and harder until this gentleman can't push the pedals round anymore. When he's at rest, he might be consuming 300 or 400 millilitres of oxygen a minute. When he starts pedaling, the oxygen consumption goes up because he's doing work, lifting his legs up and down. And then as the work rate starts to come on, he will consume more and more oxygen as his muscles do more work and demand more energy. And the gentleman in this graph stopped pedaling at an oxygen consumption of 2.5 litres. As he uses that oxygen to burn fat and carbohydrate, he produces carbon dioxide, and you can see that the carbon dioxide in blue tracks up alongside the oxygen. But then we get to a point where it starts to accelerate and overtake the oxygen consumption. And what's happening here is that the oxygen is now not quite getting to the muscles fast enough, and he's starting to supplement his aerobic metabolism with anaerobic metabolism. And this transition point here is called the anaerobic threshold. And the work to date suggests that to have a standard risk of complications after major surgery, you're looking to have a peak oxygen consumption over about 15 mils per kilo of your body weight per minute, and an anaerobic threshold over about 10 mils per kilo of your body weight per minute. So we translate that to weights to account for people being different sizes, and that seems to be the best way of reckoning it. Now, if you have a set of graphs like this and a patient like this, then surgery is unlikely to be an issue. This patient's got really quite good fitness. He might have a peak oxygen consumption approaching 30 mils per kilo and an anaerobic threshold in the mid-teens. Unfortunately, a lot of the patients I see are not that fit. The amounts that you can do and what's normal does decline as you get older, and that the challenge of surgery is seen to stay the same for everybody. And you can see here graphs from different patients with different predicted normals and lower overall exercise capacities in both the peak oxygen consumption and the anaerobic threshold. And the incidence of a lot of the cancers that I'm dealing with get higher as you get older, and you get to the point where patients are really quite elderly and might be quite petite, have very low normal predicted values and low measured values for their oxygen consumption. And this patient over here passed their anaerobic threshold really as soon as any sort of braking started to come on in the exercise test. Taking a step back for a moment, the overall population is getting older. We've got increasing numbers of elderly and very elderly patients in the population who are going to present with cancers and other treatments that they would like to have treated. We also have more patients living with comorbidities, with respiratory disease, cardiac disease, diabetes, kidney disease, and so on. Life, it generally is getting a bit more sedentary for a lot more people, and particularly over the last 2 years, there's been a lot more physical inactivity as people have done what they've been told. They've stayed at home and lost a lot of their day-to-day normal activity unless they were making deliberate efforts to exercise. Also, the surgeons are taking on more difficult operations that are technically feasible. So they're trying to do operations that 10 or 20 years ago you might not have attempted. But these are long, there's lots of tissue dissection and so on. And so the challenge for the patient can be greater. So overall, we're operating on high risk patients and we're undertaking more challenging operations. So the concept that's come around over the last 10 years is that rather than just accepting patients as they are and operating or not operating, actively working with patients before their surgery to improve their fitness in terms of physical fitness, nutrition, and psychological well-being. And that's the term that's been coined is prehabilitation. We know that surgery knocks you, and major cancer treatment knocks you, takes a lump out of your fitness. The hope is that if we get you fitter before you start, you'll be fitter at the end of treatment, and you'll have been less likely to have suffered complications that would knock your fitness further, and you'll be in a better place to rehabilitate and be able to get back to your baseline fitness, or hopefully even better. So Heather's going to talk now a bit more about the details of prehabilitation, what it involves, and what we're doing in Leicester.
So prehabilitation is it drives itself on being holistic and looking at all aspects of our patients. And so this diagram really kind of shows you all the things that we aim to do. And it's really kind of essential to the thinking of it is that it's about supporting patients to become engaged in their care to access improved outcomes. So supporting them to get out of hospital quicker and get on with living the rest of their lives as quickly as they can. Next slide, please. So national guidance was published in 2019, and this really kind of embodies this idea of empowering patients to increase their preparation for cancer treatment, as well as kind of planting those seeds, particularly around kind of those health behaviours that aren't helping overall fitness, and giving it an opportunity to be able to talk about that. These were further backed up by some guidelines that were published last year, looking at kind of how we support that whole process of preparing people for surgery, and prehab was stated as being really important there. Next slide, please. So in addition to this, in terms of the guidelines, the Chief Medical Officer's recommendations is that we should all be doing 150 minutes per day of per week of physical activity and a couple of strength sessions in order to help us all have an active life and a good quality of life. But actually, I really like this curve that shows you that actually the maximum health benefits come with making small changes. And I think that's really important while we're supporting people who are going through cancer treatment, that actually just focusing on being able to do even small amounts can make a real difference. Next slide, please. So interventions are very much come from cancer, but are spreading into a lot of other modalities, and I'll come on to that in a bit more in a minute. But a lot of trusts around the country are embracing this. It's just fairly obvious once you start thinking about it, and people are pragmatically doing what they can with whatever little pots of cash they can. So although the guidelines talk about the value of taking a holistic approach and working on everything, actually people are just doing what they can with the resources they've got. And this has meant that different places are taking different approaches. So, and you can see that they're doing it in different settings, a variety of kind of healthcare professionals or exercise professionals supervising these interventions. And also it's being embraced by kind of the dietetics and the emotional kind of health kind of perspective. And delivering different things, whether that's education in terms of a surgery school or exercise, taking a variety of approaches, and people are working with patients for as long as they can. And for some people, they're getting really good results from as little as 2 weeks. Others are supporting people for longer, depending on the resources they've got. Thank you. So taking those Macmillan guidelines, the idea is that the gold standard should be that we'll be supporting people to improve their kind of physical health, often through exercise, and combining that with making sure that we're getting the nutrition right and supporting their mental health. But that using this triangle, you can see that different people need different levels of support, and actually the same person might need different levels of support for each of these three components. So you might need somebody who's really needing really specialized input for their nutrition, perhaps because of the site of their tumor, but actually their mental health, they're coping really well with this, but their exercise is then having to be adapted and with that sort of targeted level of intervention to support. Next slide, please. So what are we doing in Leicestershire? The first thing is that we've actually got two different services, and I'm going to tell you a bit about both of those. The first is very much come from cancer, and that's where a lot of these things are, but also we're running an orthopaedic service that's showing some really positive effects. So starting to talk about the cancer service, because this was where we started as a team. We were very lucky to get a little pot of cash from NHS England to run a pilot service, and we opened the doors on that in February 2020. Based on those guidelines, we've really taken the view about ensuring we do a holistic approach, and actually the first thing we do is spend an hour really chatting to the person, getting to know them, getting to work out what their needs are, thinking about those modalities and the level of intervention they need. And for the cancer patients, we're using a CPET test to ensure that they're fit enough to engage in what we'd like to support them to do, but also to drive some of the values to determine the exercise prescription. We're really proud that we're able to deliver this in partnership with services across the county, and the cancer service is delivered in partnership with the National Centre for Sports and Exercise Medicine and the Active Together service. And I should have put on here, and I apologise, Leicester City Council, who let us use the gym at Ayleston Leisure Centre. As you can see, we're in 5 locations, because what's come through from kind of the services that are ahead of us on the curve is that actually it's really important that it's delivered locally. And we really like the idea that we're delivering this in leisure centres. This is about being as well as you can, rather than being yet another hospital appointment, fighting with the hospital parking and all those kind of issues. And it's really lovely that we start breaking down some of those barriers for people who've never been in a gym before, really aren't comfortable in leisure centres. And actually we can just say, well, come and have a chat with us, and then we'll see where we go from there. And you just start introducing these concepts and get people really engaged. We screen for those other elements as well as focusing on the exercise. And our COVID keeper, if you like, is that actually we've got a fully remote service that wasn't in our original plan, but was something that we really had to come up with on the hoof in March 2020, as did many other services. But that's really given dividends for the people who, for a variety of reasons, would struggle to engage in a face-to-face service. Next slide, please. So who are we working with for the cancer groups? We wanted to make sure, because we were a pilot, that we were delivering enough of an intervention that we could be certain we could make a difference with patients. And as such, we started with the patient groups who had 6 weeks in their pathway to surgery. And you can see on here the tumour sites that we're working with. And yes, and we will support them both during kind of chemo or radiotherapy, if that's their pathway to surgery, or for the people who are going straight through to surgery. Next slide, please. This comes from our esophageal pathway, and again, it just gives you an insight into how this fits into what people are going through on their cancer pathway. So for these cancers, what we actually do is wait until the cancer team have made a decision that surgery is the way to go for treating this person. At that point, the cancer nurse specialist gets in touch with us and makes the referral. We give them a ring, as I said, and book them to meet us either on the phone or online, or in person, for our initial assessment or chat. In a perfect world, we'll see them for a couple of weeks before kind of treatment starts, so that we can all get to know each other and build that rapport that's really important to this service. And also sort their exercise technique and make sure they're getting the best from the exercise. And then whilst they're going through treatment, because their immune system is affected, we ask them to exercise at home. And then when they've come through their treatment and had a couple of weeks to just get back to feeling perky, we'll get them to come back into centre, we'll repeat an interim assessment, and then if they'd like to, we'll offer them the opportunity to come back to that in-centre service, and then we'll do another final assessment within a few days of surgery usually. Thank you. So we were presenting our business case to expand and grow this cancer service, and actually the commissioners said to us, this is really great work, but do you think you could take some of your learning from here and see if we could help address the issues that we all knew were happening with the waiting lists for elective care? Because equally, not only was the waiting list really long because of the effects of the pandemic, but actually when they started operating on people, they realised that because of those effects, particularly as Andrew was alluding to earlier, that people have been less active and might have eaten a few more chocolate biscuits. I know I did during the pandemic. Actually, people were actually getting more complications and staying in hospital longer, which was exactly what the system didn't need. And so they found some cash from the elective recovery fund, and supported us to start a service supporting people who were waiting for a hip and knee replacement from the Leicester City area. We took a lot of what we knew from the cancer and kind of adapted that to support these patients. Can you move on, please? So you'll see a lot of commonality between what I've described already. Again, we've got 5 sites, but this time they're all within the Leicester City area. And we started kind of moving the wheels on this kind of August, September last year. And I was really proud that we were able to start delivering this in December. We took the waiting list and we're actually calling people and triaging them to support the people who would like to come and join this programme. It's 12-week face-to-face and combines kind of weight management with exercise and some educational components. Thank you. So you can see that both of these services are working with partners from across the system, and this is something that's really paying dividends and is a really nice way to work. When we were designing the Orthopaedic Service, we did that in combination with kind of the therapy experts from in the hospital, sports and exercise medicine professionals, of course, with the team that would be referring, and kind of use that to drive this forward. We work, as I said, with the exercise professionals from both the city and the county areas, and actually we're really excited to be able to start doing some data analysis with Loughborough University. We really think it's important that objectivity of having somebody else look at our data should reduce the bias in our results. So we're really looking forward to that. Thank you. So going back to the nitty-gritty of what we're doing, as I said, we screen our patients to ensure we're meeting all their outcomes and addressing all those behaviours. You can see that there's some difference from how we do this within the two services. And actually the weight management is almost diametrically opposite. So with quite a few of our cancer patients, we're actually working really hard to make sure they're not losing weight, and working really closely with our as colleagues in the kind of dietetic service from within the hospital and within the home enteral nutrition team and things. Whilst in orthopaedics, we're actually delivering this in tandem with the weight management service for the people that need it, so that we're helping people from both aspects of nutrition to optimise their body composition. You can see that we're also looking at smoking and alcohol and frailty, and really having an overall view of these patients. Thank you. We use assessments for both services. We'll assess them before and after, because only by doing that can we check that we're actually making a difference to these patients. But you'll see that they're slightly different based on what we're doing for these groups. As Andrew said, the cancer service is driven by the CPET service, but actually in the orthopaedic service, actually the functional measure of how far can you walk in 6 minutes is something that's really important. I really like the sit-stand test, which is literally how many times can you stand up in a minute. And this is something that kind of makes intuitive sense to people. They know they're fitter if they can do more of these. And it's also was really useful during the pandemic. It doesn't need a lot of space. I could do it on a video call. It's really useful. You'll see there's other commonalities. So in both services, we take body measurements, slightly different ones depending on what we're looking at, and then we use a range of questionnaires to explore kind of the symptoms and the burden that those place on people for what each are living with. So they're different between the two services. And then the final thing that we use is an experience measure, so a PREM if you like. It's called the care measure, and allows us to get some feedback and make sure that we're doing the right things for our patients. Thank you. The other really important thing for kind of the wider NHS, as well as for patients, is actually, are we helping people get home and get on with their lives? And there's a really nice measure called Days Alive Out of Hospital 90 that measures, as it says on the tin, how many days are the people at home and alive within those 3 months. And it's really nice because it actually rolls up quite a few of those kind of different measures that are used into one number. We obviously use the kind of subsets of the data of that, about how long are you in intensive care for, how long are you on the ward, as well as kind of exploring who's getting complications and how long it's taking them to recover, and kind of how severe those complications are. Because as Andrew alluded to in the initial few slides, we really hope with Prehab that we reduce people's risks of getting a complication, and if they get one, we really hope that they've got that bit more resilience to be able to bounce back from it quicker. Thank you. So exercise wise, these two services are designed differently, because actually what these people in each of these groups need is different. So in cancer service, what gets you through your surgery and home again is actually your cardiovascular fitness. The evidence shows that actually combining that sort of work with strength, you get better results. So that's where we're defined. Whereas the orthopaedic service is taking much more of an approach to it. Yes, improving the lower limb that we're planning to operate on, but also working on your upper limb strength and your core strength, because getting you able to get going on your crutches up and down the stairs is what drives, can you get home and get on with your life? The orthopaedic service is much more chair-based, as you can see from my little picture, and that's about making sure everybody can access it, no matter how kind of bad their leg that's waiting for surgery is, and it makes it accessible. So yes, thank you. A really important component of the orthopaedics is actually this education component. the vast majority of it, so 7 out of the 10 sessions, is actually nutrition based, and my wonderful colleagues in the Leicestershire Partnership Trust Dietetics and Nutrition Service deliver all this, and they took their really well established LEAP programme and adapted it so that it fitted into the confines of what we're trying to do here. And here you can see 7 of the potential topics that they will cover, but they are brilliant and they really adapt things based on what each group needs. My colleagues who are working on this service are also doing education sessions, and you can see the sort of things that we're covering to give people some of the coping skills to be able to come through that surgery, know what to expect, and be able to kind of engage in their rehab and come through it. Thank you. The staff that work on this has been an interesting kind of thing, and again, this is something that's done differently in the different prehab services across the country. Allied health professions are quite often heavily involved, depending on their design. There's quite a few physios like me, but also you'll see kind of other roles, and often they bring their own flavour to design of the prehab, and that's brilliant. Quite often in the different centres, the exercise instructors suitably qualified are delivering elements of this in the leisure centres, and that's certainly true for us, as well as actually kind of empowering the cancer nurse specialists and the rest of the cancer team to deliver that universal advice, which is very much in keeping with that kind of making every contact count kind of ethos. I have to say, clinical exercise physiologist is something that's really coming to the fore in the last kind of year. They've actually created a registration scheme, and this is something that we're embedding in our service, and I think is really going to be the way forward. I should say this goes across the board, and actually we've got kind of nutritionists and support workers involved within our Leicester team as well. Thank you. Digital nature and gadgets is something that's very popular at the moment, and kind of we've made our own. In the bottom corner you can see our surgery school videos that we made for the cancer service that talk patients through kind of what's going to happen when they come in, and provides that rounded education, whereas obviously in the orthopaedic service we do that face to face. And we're actually using MyZone's activity monitors that gives our patients real-time feedback about the intensity of the exercise they're doing, as well as uploading data that I can access, to check that they've done their homework, but also to ensure that they're exercising effectively. And there are real uses. I've got some people who absolutely love this, and they're really motivated by getting the points and making sure they hit the next badge and this sort of thing. And again, it gives you that flexibility that yes, they can feel that they're being supported and monitored, but actually they can still do it around all their other commitments. And it's probably cheaper than actually kind of paying people to deliver this face to face. I think the negative of that, it's amazing how much, and we found this when we restarted face to face as the pandemic started to wane. It's amazing how much people get from just being sat on a bike or on a chair, depending on the service, and interacting with other people who are going through the same things. And actually we get a really nice banter between the team and the patients, and people clearly get quite a lot from that. And I think this is almost going back to that point about making things holistic. Yes, digital services are lovely and really useful, but it's not one size fits all. Thank you. So to give you a snapshot of some of our results, I will give you the caveat that we are waiting for that proper detailed analysis from the experts, but this is where we're headed. Thank you. So this is where we're up to. So at the moment, we've had 390 referrals through to the Cancer Service, and I'm really proud of the team and how well kind of our patients engage with us. So those shows you, so even if you add our 10 and our 20 together, that's still less than 10% don't engage with our service, and I think that's amazing. You can see kind of how many assessments, and our wellness checks is when we're checking in with everybody every week. Sometimes that's on the line, on the phone with the people who are working remotely. Other people is when they're coming to see us in the sessions. And currently we've got about 49 people engaging in the programme across our remote and our face-to-face across the 5 sites. The Orthopaedic Service has, as I said, been running since last December, and it runs in 12-week cohorts rather than our cancer service. So whenever you get referred to that, you start. With the Orthopaedics, we take a group of people, and that really works nicely. We get a nice group cohesion and really supports, particularly when you think about that weight management stuff. People are sharing stories and really learning from each other. So run differently, and we've completed 3 cohorts. You can see that of the 91 who started, 62 completed, but actually 20% of those people who didn't complete actually went on to have early surgery. So I think if you could put those 2 together, it really shows how much people are valuing what we're doing and just keep coming. Our 4th cohort is currently in process, and with 38 in that programme. Thank you. So in terms of kind of some numbers for this, so this is that standing up and sitting down test that I talked about a few slides ago. And the data that you can see here is the people who are going straight to surgery, what happens during, so the pre and post effect of going through chemo or radio, and then between finishing your treatment and going for your surgery. So those are those 3 stages that you can see. And I will hold my hands up that there's big standard deviations and massive ranges in this, but actually I'm just really encouraged that the changes are really quite positive. And you look at the numbers people are doing, and you're kind of seeing 10% improvements in each of those stages, which is really good. Next slide, please. I'll just give you a second to read this quote from one of our patients. And for me, this was just really powerful. It actually gave me a little bit of a lump in my throat when I heard this. It's just really nice that I get to make this much of a difference to people with what we do. Thank you. And then these are some of the things that the professionals have said. And again, I'll just give you a second. Thank you. So now going through some early results from the Orthopaedic Service, and as I said, this is really early doors. We've only got kind of 3 cohorts of data, but again, you can see these differences. And again, you've got the same thing, so how many times can you stand up? And you can see actually that number's much lower than we saw in the cancer data, but actually the change is really significant. And in terms of their ability to be able to walk, to live their life and get the shopping and everything else, again, you can see, you know, an almost a third of an improvement there. And when you think that these sorts of the differences that are deemed to be clinically significant when you're kind of looking in other disease groups like respiratory disease or heart disease, where kind of 45-50 is considered to be a really important difference. We don't know what that value is in orthopaedics at the moment, but it starts to give you a feel for how much this makes a difference. Also seeing a really encouraging trend there in the weight, and often as you kind of lose weight, these things all kind of build positively on each other. So that's really encouraging. Thank you. This is one of the lovely ladies who came to our session in Beaumont Leys, and again just gives you, the quotes from her are lovely, and I have to say typical. Patients are just really getting a lot from this, and they're feeling being supported. But in terms of, if you think about the reason people choose to have a joint replacement is because they're not able to do what they want to, so their physical function is affected, and also their levels of their pain. So the fact that we're demonstrating, she's almost doubled how many times she can stand up and significantly improved how far she can walk. This is absolutely brilliant and really a testimony to the team. Thank you. Right, where is Prehab going to go next? Thank you. Right, I would love to see it integrated with kind of the rest of the pathway and really embedded as standard practice. I think kind of as an NHS, we can make some benefits by talking to each other more in those different pathways between everything that happens as you prepare for your surgery, your visits to your anaesthetic, your CPET, and embedding all of those and those multiple contacts to really embed the importance of preparing and really changing waiting lists into preparation lists. And I think that really helps. I think that's what we've seen anecdotally from patients, is that they appreciate having something that they can do to contribute and make themselves as prepared as possible. I would also like to expand the service and kind of I really appreciate that we're only working with some tumour sites, and I would really like to support the people who are having treatment for other pathways and kind of start supporting the people who are on a really quite quick pathway. The evidence is showing that up to 2 weeks can make a difference, and that's something we'd really like to do next. There's also more and more evidence that kind of supporting people in going through curative treatment that's not just surgery is really useful, and so we'd like to do that. Orthopaedics, we hold our hands up, we're only doing city. We really want to start working across the rest of Leicestershire and Rutland. And also there's a whole kind of cohort of people who are having non-cancer surgery who, for a variety of reasons, could really benefit from this sort of support to prepare themselves. Thank you. There are loads of research questions and there's so much to kind of explore about what is the key ingredients and how much of that key ingredient do you need to do. The NHS is constantly looking to make sure that services we provide are value for money, and we can only ensure we're doing that by making sure that we're delivering the right amount and at the right time point to the right people. So there's questions about who is it best for and how much does each group need? What are the barriers? Kind of really trying to explore at the moment for the people who aren't taking up offers. What is it that we can do to adapt the service to make it suitable for them? You have to meet the patients where they are and support them. So it's kind of exploring all that. There's some really quite interesting questions just starting to emerge, and we probably won't get the answers for a long time on this, but actually it's comparing the benefits of prehab compared to the risks of delaying surgery, and I think that's a really interesting question and something to look forward to. So thank you. Next slide. So in conclusion, prehab is becoming part of standard care, and the research to support that is continuing to develop, and we're really hoping to be able to contribute to that soon. It is necessary. We cannot keep doing things the way we always used to, and that was true before we had a pandemic. So we really need to adapt and work smarter. That's a horrible phrase, I'm sorry, but yes. We have started a pilot service for 2 separate patient groups, as you can see, with quite different designs, and we're seeing some really encouraging results from that. We really want to expand. We want to help more people, and actually kind of really quite keen to develop some of this sort of surgery school to really support that education and support engagement. Next slide. I think that's my last. Thank you. I don't know if you want to stop screen sharing, Andrew, and see if anybody's got any questions.